So there's a lot of things that, we can certainly talk about with, when you're talking about and patients come in and what do they tell you? Well, I've been having diarrhea. The first thing you should do is to ask them, what does that mean? And we'll get to that in a second. But with this talk, since we're talking about C. difficile, and for some reason I can't get to anything.
Oh, sometimes you have to just click in the middle of the slide, click on the screen, and then
Okay.
now you can.
We owe a huge debt of gratitude to these people, especially Sid Feingold. Sid was one of the giants in infectious diseases who passed away a few years ago. And as part of his legacy, if you remember another organism that's in the mouth, that was Streptococcus magnus. They renamed it after Sid, so that's why it's Feingoldia. So he did a lot of things. The best thing, in my opinion, that Sid and his crew did for us was the taxonomists wanted to rename Clostridium difficile as a Peptococcus, or Peptoclostridium. And these guys went, this is insane. So, they went through this. This was back in 2016. Maybe this will work now. There we go. So the taxonomist said, no, we need to change it to Peptoclostridium difficile because of the changes in our RNA clostridial clusters, blah, 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 as you can read there. And so we need a new genus name. And if we change that, we're going to change things to PDIF, PDI, PDAD, which sounds like P. Diddy, but I won't go there. From C. diff, CDI, and CDAD. So that group had a counter proposal and he said, this is crazy. We're going to have to re-educate all these people. And they said, that's not our problem. We just do changing names to confuse the innocent, which is us. And so they said, why don't you change it to Clostridioides, oides meaning like. So it's a Clostridium-like organism. And there's only two species in Clostridioides. Clostridioides difficile and Clostridioides magnetoti. I don't know if I say it right. Mangenotii, sorry, which isn't even a human pathogen. So really in that class, there's only one human pathogen. They said, oh, okay, fine. So thank you, Dr. Feingold, because without that, we'd be having a lot of discussions with people who would still not know what to do with this. So what's the definition of diarrhea? People tell you, why have you having diarrhea? Well, tell me about your episodes of diarrhea. Well, I have diarrhea. Okay. How many times a day are you going? Well, I do it a couple times a day. Well, and what's the consistency of it? What's diarrhea? Is it loose like water? Well, no, it's just kind of like, pasty potty. Well, that's not really diarrhea twice a day and that kind of consistency. So you want it to be, as we tell people, 3 and more in 24. So you want to have at least 3 loose stools. And we'll talk about the Bristol stool scale here in just a second, so that we're all in have a consistent definition for this and something for you to think about going into the holiday season. Obviously, diarrhea can have a lot of different reasons for it. Some infectious, some non-infectious, and our GI colleagues see a lot of the non-infectious things too. So, and sometimes both are mixed together, which is a real conundrum for both of us. So. For those of you who aren't aware, this is the Bristol stool chart, and you see it goes from type 1 to type 7. We're generally interested in type 6 or type 7 with real diarrhea, because when you look at that in a container, you tilt the container, it assumes the shape of the container. If it doesn't do that, probably not diarrhea. So this is very helpful, I think, when we talk about it, and we would show this to people in some of the C. diff trials that I've been involved with here in the past. One of our subjects in one of our trials in a vaccine trial, the C. diff vaccine trial, which unfortunately got closed because of futility. Nobody was getting C. diff. That he brought it to me and the coordinator that we had at the time, a cup for a Christmas present. And when I opened it up, it was what you see on the bottom. It had the Bristol stool chart on it. He thought that was hilarious. I was amused. I said, what are you going to do with that? I said, I don't know. I guess I'll make a crappuccino. He was quite amused with that. So, but you can get T-shirts, you can get shower curtains, you can actually get chocolates that look like the stool chart. He said, I was going to do that, but I'm afraid you wouldn't need it. I said, yeah, I don't think so. Sounds bad.
Type 7, I'm not going to.
Yeah, I'm not going to. No. And just for information, you will probably notice when they talk about about with CDC at this point, that CDC put this in their AR threats report. So these, resistant bacteria is included when you start looking at carbapenem-resistant Acinetobacter, which is a real problem. Candida auris, as most of you know, is also a real problem. The carbapenemase-producing organisms and drug-resistant Neisseria gonorrhea, but C. diff is put into that as well. So it is something that we look at. NHSN wants this reported, the cases of C. diff, so does the VA for us here. And it is something that we watch, and we watch it for a couple of different reasons. One, for patient care, and the other for epidemiology and reporting that we're doing for NHSN purposes as well as for the VA, because they're interested in this as well. It's part of the MDRO program. So when you start looking at this, and this is data from several years ago, from 2017, you see the number of estimated cases because nobody knows exactly. Some of these that get treated as an outpatient, they don't get reported and stuff. So it's a best guess. Out of that, about over 12,000 died and cost us at least $1 billion in 2017, which would probably double that now. So the community cases, haven't really decreased. What we've seen is hospital cases decreasing because of a lot of things that we've done trying to prevent hospital transmission. One of the first things, if you have somebody that gets admitted to your hospital within the first 72 days, if you really think it could be C. diff, you should test them before that 72-hour clock runs out, because if it's done after that, they're going to assume it's hospital associated no matter what. You can't, but it wasn't. And then your hospital will get dinged, and it's a CMS. Oh, you should have, you shouldn't see this in a hospital, and then they may not pay the bill after that definition, and for some other things as well. So that's one of the reasons why we're very interested in this and follow these cases. There have been some papers that have come out. You see, this is New England Journal paper from a few years ago now. That was looking at the burden of this, and it goes from 2011 to 2017, and shows us that, C. diff it's not going up by leaps and bounds, but just as community associated, which really hasn't decreased a significant amount, as opposed to when you look on the right-hand side in the upper part, the hospital associated cases, which have been decreasing, at least in that time period, and continue to do that, with a lot of relatively easy things to do. We were having a problem here, and we started investigating many years ago. And we found that when patients came in and they got put in, precautions room, when they got when they got discharged, the nurses would go take the sign off the door for the Contact Plus, and then call EMS up to clean the room. EMS doesn't know who's in the room. They just terminally clean it like they would anybody else's room, but they don't terminally clean it with bleach like for C. diff. So all it was simple. Said leave the sign till EMS comes up, and they know who's been in the room. They terminally clean it. I said, these are laminated. They'll even wipe it off with bleach and give it back to you. And that actually helped decrease, our rates of C. diff. Not to zero, but it helped in the hospital of decreasing. This is a paper that was in Anaro back in 2020. And it was looking at, as you can see, the same kind of thing, and looking from 2011 to 2016. And you see some names in there that have been associated with C. diff, like Dale Girding, Stu Johnson. And so they were actually looking at the different ribotypes. Remember, this isn't one bacteria. There are different ribotypes. It's like Streptococcus pneumoniae. Yeah, it's one organism, but there are different subtypes of this, or serotypes of it. And we have gotten really interested in that 027 FINAP1 type because of its potential to cause a lot more toxin production than some of the others. So they've been following this along, and then what you see is back in, the 027 has been decreasing in their studies when they started looking at, different hospitals. They saw the same thing in this one, which is actually coming out of the VA. And this has been a few years ago as well. This is in 2018. There are not a lot of VAs that actually ribotype their C. diff. So it's hindered by that. But even with that, in the places that were doing it, they saw, you can see with the arrow for the South Atlantic VAs, we saw decreases in C. diff overall. And then I can't see the bottom of it, unfortunately, but if you look at the first, I think it was 1A. Yeah, you can't see it on there. I think these are 1A hospitals, which would include like our VA. And this is the same data and looking at, you know, the pineapple and 027 strains, uh, and kind of color coding it. So you see over the years, for all the years where things have gone, but as the years have gone along, we see some changes. And for 2016, it looked much better, especially for Florida with this. What they used was a couple of different platforms for this. They use, like we use here, the Cepheid Expert C. diff. And there is a cartridge that you can use for this that will tell you epidemiologically if it's an 027 or not. There's also another platform, the Luminex Verigene, which can give you similar information. So we see things changing over the years. We're seeing not as much of the 027, which I think makes all of us happy, because these people tend not to have as much toxin produced. They usually aren't as sick as what we've seen in the past. And unless they just wait till the last minute to come in, usually not septic from this, or have a dying necrotic colon, which is going to end up being removed and maybe or maybe not save their life. Yeah. There you go. Kurt's eating breakfast, so I showed him this picture. He enjoys it so much.
Thank you.
You're welcome. So we had seen the severity of C. diff getting, you know, really bad because of the 027. And that's where everyone was worried about as we went into, you know, the early to mid 2020s. Although we see things now starting hopefully to turn around some. And I think part of what was going on with this, like a lot of different things, was, guess what, that we had starting in 2020? COVID. So a lot less people were, you know, congregating around. There was less chance of them sharing things. But we still have C. diff that's still going around. The best guesstimate from CDC is about 500,000 cases a year. About 1 in 5 will have a reoccurrence. 1 in 11 people over the age of 65 died in a month of having C. diff, and 80% of the deaths occurred in that same age group. And then we'll talk about testing. This is looking at, you know, just the production of toxin A and toxin B. The reason that we got really interested in 027 was it had 16-fold higher levels of toxin A and 23-fold higher levels of toxin B. Plus, it also produced a binary toxin. So this was really, really toxigenic. And people just didn't do well with this. When you start stooling out, you were stooling out a lot. And if you think about it, I mean, your body's way of trying to get rid of it, you can't take a shovel and get rid of it. So you're really upregulating cyclic AMP and literally trying to flood it out of your body, if you think about it that way. Obviously, there are a lot of other immune regulatory things going on here, but that's why people just have tons of diarrhea. It's just, you know, the effects of the toxin and your own immune system trying to deal with it the best that you can. I'm going to talk a little bit about resistance, but yes, most of these are really resistant to fluoroquinolones. I was going to have a very nice graphic talking about bile acids, but Kurt took it out because he didn't want me to talk about it. So I don't know what happened to it. I'm really sorry. I can send this all to you once I get back to my laptop because it's on that. But just remember that when you're making bile acids, that do they normally go down to your colon? The answer is no. They usually get reabsorbed. You know, you're making bile to do what? I mean, what's it normally do? Is there a function to bile? Yeah, it emulsifies fats, so you can absorb them, right? And some other things.
Oh my God.
But, I'm sorry, did somebody have a comment? Okay, so bile acids do that and some other things, and bacteria can make bile acids as well, as has already been commented on. But most of these are going to be reabsorbed in the small bowel, unless that there are issues in the small bowel. And this is a really hot area where people are looking at, can we use some bile acids, maybe therapeutically, like ursodeoxycholic acid and some other things. So stay tuned. I'm going to show you a couple of things, I think just one thing at the end, because DDW, which is the big GI meeting, just happened last week. And there are some things, I haven't had a chance to scan through all their presentations and things, but this is something, you know, that is getting a lot of attention, as are a lot of things with C. diff, trying to have better tools so we can treat people. So the reason that this was put into the MDRO and other resistance is because of C. diff's virulence mechanisms and AMR genes. One of the things people forget is that C. diff actually can make biofilms. It can make biofilms in the gut. It's like E. coli making biofilms in the GU tract that we're becoming more aware of. There are some mobile genetic elements within different C. diff ribotypes, like these transposons that include TN 5398 carrying ERM-B resistance. And that gives you, unfortunately, resistance to not only erythromycin, but some other macrolides as well. You see alterations in metabolic pathways and targets like RPOB conferring resistance to rifamycins. That's one of the reasons why people start using rifaximin and some other agents trying to use this as prophylaxis. It did okay, and then it started failing most of the time. And it's not a cheap drug to use. The big thing is fluoroquinolone resistance, primarily to Cipro, but to a lesser extent to other later generation quinolones. And usually it's mutations in DNA gyrase, as we see with other things. So GyrA and GRB. The most common mutation I was finding was a substitution of THR82 LLE and GyrA. So that's the big thing. All you have to remember is DNA gyrase resistance to both A and B. Cephalosporin resistance is very intrinsic in C. diff, mediated by the production of class D beta lactamases. So when you start looking at, the association, this is back from 2015 in New England Journal, which I thought was a nice discussion. Very common things to think about is some of the things we just talked about. Somewhat common you see listed on the left-hand side from other penicillins and occasionally, sulfonamide, trimethoprim combo and macrolides because of the resistance that we just talked about. But uncommon, not impossible, but uncommon, and even not on this list, Vanco could be on there as well because there have been a few cases of people that have been on vancomycin developing C. diff. There's also some people that have developed C. diff because of dietary changes from chemotherapy. So it's not just antibiotics. It can be a lot of different things. But if you're trying to keep people who've had C. diff in the past, and you can use some of these antibiotics, especially tetracyclines like doxycycline, have really uncommon rates of C. diff associated.
How about piperacillin tazobactam? Something seems to tell me it has a lower Clostridium difficile risk.
Well, it's a penicillin.
Well, that's what I was going to say. I know you have it listed as somewhat common, but yeah. To me, I see less of it with piperacillin.
Well, and then some people are arguing, what about the anaerobic coverage? The other thing that is not on this list, it's last on the list, is tigecycline. The original registration trials had no C. diff, but there have been cases of C. diff, not very commonly with tigecycline, and some people have used it as a form of therapy for that. I knew the people at Wyeth when this came out, and I said, y'all ever thought about using tigecycline orally? Because it's not absorbed. It'd be like oral Vanco, and oh my God, you'd think that, it just exploded an atomic bomb, because if they were to do that, they'd have to start all over with phase 1 trials and go, because it's a different route of administration. Could it work? It's not absorbed. It might, but did they want to deal with it? No, because other people are looking at stuff at that time. And then Pfizer bought Wyeth. That was the end of that.
Is it available at all? You know?
No. Could we do like we used to do with Vanco because it was cheap to make it IV and then give it to people?
Oh, yeah.
I don't know. Have people done that? I haven't seen anybody talking about it. So if they've done it, they haven't published it, as far as I know. But it could be interesting, although there's a lot of, I'm going to mention something else that's actually in phase 3 clinical trials that looks interesting. So testing, the middle bullet there is the best. Tests are imperfect and they're evolving. I recall telling people that, years ago, I had called to see this lady who was symptomatic. She had a fever. She had like 8 to 10 loose stools a day. And of course, when they consult you Friday afternoon at 4 o'clock. And so at that time, the drug of choice was metronidazole because they were worried that vancomycin was causing, oral Vanco was causing VRE, which didn't happen. But that was the concern. And so people moved away from oral Vanco to using oral metronidazole, which is really well absorbed, but there is an intrahepatic circulation. So you're still getting it in stool. And so I ordered all the tests that was available was a stool EIA. See, that was it. So we ordered this stool, saw her over the weekend. She did better over the weekend. Fever went away. Stools were less. And by Monday, she was about 85, 90% back to normal. The C. diff EIA came back negative. Did she have C. diff? Yes, clinically she had C. diff. She had all the markers. She got treated with a drug that can work, and it resolved her signs and symptoms. So that's what she had. Now, as people, well, maybe she had a spirochetes or something like that. No, she had C. diff. So that's part of the problem with this, is having really good tests. And so if you look at what we have, this is what we have. We have the best thing ever was toxigenic culture, but it takes a long time to do. And, we have less and less techs and micro that can do this. The sensitivity is very high. Specificity is obviously low, because what it's detecting is C. diff vegetative cells and spores. The next best thing on here as far as sensitivity specificity is actually NAT testing or PCR testing, whichever you like to call it. It's very sensitive. Specificity is usually about moderate when you start looking at the data. The next best test is glutamate dehydrogenase, or GDH. The sensitivity is very high. Specificity is really low because C. diff, this test will be positive if it's toxigenic or non-toxigenic C. diff. It just tells you that there's C. diff there. It doesn't tell you if it's making toxin or not. As is the NAT test. It tells you that there is C. diff there that has genes that can code for toxin, but it doesn't tell you if they're working. So it just, it tells you it's a good chance that that's there, or it tells you that's there, but it doesn't tell you if it's active. Probably the best test ever was the cell culture cytotoxicity neutralization assay. It was the best sensitive and specific test. It detected free toxins, but it took like 4 days. So it was very laborious in micro, and obviously you're dealing with stool, and even under a hood, it's not pleasant, so people didn't like it. And actually the lowest sensitivity with this, it's not bad, it's just not as good as some of the other tests, is toxin A and B enzyme immunoassays. But this is what we do at this point in time, because people were getting, and I didn't put all the data in here, but if you're getting PCR, even if people have loose stool, is it really C. diff? We're only looking at, okay, it's there. Is it colonization, or is it active? Is it making toxin? And that's been the argument. So that's one of the reasons that they came out with 2 ways of doing this. One was you can do it either as separate tests or like these combo systems. And this is just one that I picked, that you're looking at on the left-hand side of this. It says antigen. Well, that's GDH. And then you have toxin on the other side. So it's looking to see if there's C. diff there. So like you see in the middle, antigen's positive, C. diff is there. And then on the right-hand side of that top graphic is that, hey, it's making toxin. That's a positive test. So in some hospitals, you'll see them doing this. And it's reported out. I showed this to somebody, and he said, I think it looks like Epic, because it looks like how Epic would report it. I don't know. I haven't dealt with Epic. So you can tell me.
Interesting. So it's like ... for negative, and then
no, it's a line assay.
line assay.
So what you're seeing is the line on there.
Right.
Yeah. As somebody told me and said, is this a pregnancy test? No.
One line.
No, it's not.
One line is antigen, 2 line is
Yeah.
antigen.
If you see just the line on the left, that tells you antigens there. If you see the one on the right, that tells you toxins there. Can you get some screwy ones on that? Can you get a toxin positive, antigen negative? It's come up, something went wrong. And so what happens if the antigen's negative and toxin's positive? Then you reflex it to a PCR and see if the PCR is positive. So it like I said, it's not perfect. There are some things that get really screwy. This is what we're doing here. We started doing this on the 7th of February of this year. We were having a lot of issues when people were ordering C. diff because they were 2 separate tests. You could get a PCR and you could get a toxin. Most people would order one or the other. So we didn't get both of them together. And realistically, you should have both. If they got a PCR and we said you should get a toxin, what did they do? They ordered a toxin, but they had it as lab collect. The lab doesn't collect this. This is a word collect. The lab doesn't have enough people to go up and start saying, hi, I need some poo. Here, give it to me. So the order would get canceled and it wouldn't get done. So now what we do is one stool specimen is sent down and the test is ordered as a reflex, and that's all you see. The others went away. So this is what happens. So the big machine, if you haven't been down to micro, and it's very common among hospitals, is, as they called it when we got it, the beast, because we do all kinds of gene expert testing on this besides C. diff. We did COVID, we did the quad test for, flu and RSV, all these little cassettes that they have. So that's the C. diff one. I don't think we're using the epi one. So it goes into the gene expert, and then it depends on what happens with that. If it comes back PCR negative, that's it. Test report is negative. If it comes back that it's PCR positive, then it gets reflexed on that same specimen, which is still there. To this card is what we use here is the Ramel expert C. diff toxin A and B. It's also a line assay as well. And it does come up once you put it in there, there's a control line to tell you that, yes, the test is working and what the test positive, if it's positive or negative. So if it comes back the EIA is negative, it's not C. diff, unless clinically you really think that it is. And, you know, and when this is a real problem is somebody who's got a history of IBD. And we don't know if it's C. diff that's causing this, or it's a flare, or could it be both? And that's where the conundrum comes up. But if it's positive, then it's probably going to be, with few and far between issues, going to be C. diff. But again, this isn't a defining test. This is a test to help give you information so you can make a decision about, is this really C. diff or not, and should you treat it or not. The one thing that I think will help with this is if it comes back PCR positive, it tells you that they can be colonized. So, what do we do with that? I still, I'm not a huge fan of carte blanche, just profiling people when they come in if they get an antibiotic. That data is kind of here and there at this point, but it is something that we still have discussions on, and I'm not going to go there with this today.
It's the low sensitivity, it has a lower sensitivity, right? The
Exactly.
EIA.
Yeah.
Take it with a clinical picture. If it's PCR positive,
Yeah.
negative.
Yeah. The way I've told people is it's like getting for syphilis, getting a DPPA and it's positive, then getting, an RPR. Well, okay. Well, you need the RPR because it is the way that you're gauging therapy, but I mean, similar but different. So this is just showing you what, since the 7th up through when I ran this on the 24th, I was meant to run it yesterday and I got busy and didn't. So we had, out of this, 221 tests ordered. 86% were negative for PCR. Out of that, 23 were positive for PCR, but negative for EIA, and we had 9 that were positive. So what does that tell you? Out of 221, we had 9. There's a lot of testing for C. diff that goes on, maybe over testing. So we'll have to look at this after 6 months and see, do we need to make some recommendations about really, but at this point. So they only do it if it's Bristol 6 or 7, and they do it exactly the same way that we just talked about. And I also ran it to see where were these collected. And the lines with the Arizona are all outpatient. So most of these are outpatient, which tells you that that's still most of the issue with us is still outpatient, where people are initially manifesting this. So early on, and a lot of this is going to be history, is looking at the original SHEA and IDSA 2010 and 2017 guidelines, only test unformed stool. We had an interesting cardiothoracic surgeon who saw the guy had C. diff, and he didn't want to cut on him until we made sure it was totally eradicated. Well, he's not having any stools or anything, so he had a formed stool, told the nurses to put some water in it, send it down for C. diff testing. I got alerted. I said, no, you will not. He said, well, I'm not doing the surgery unless C. diff is not there. I said, well, that's against all the guidelines, and that's your decision. But if he has a bad outcome because you didn't do surgery, it's on you. And so he finally decided that, okay, fine. If you're saying it's okay. So he's having foreign stools. He's not having active C. diff. Could he be colonized? Maybe. So no. So all these things that help people is, if we don't need a test of cured, a lot of people think we need a test of cured. No, you don't. It's like, oh, well, if somebody had a urinary tract infection, they had cystitis. Well, I have to get a urine to make sure it's gone. No. If the symptoms are gone, leave them alone. Because you're just going to make it worse. You're going to cause resistance, and that's a completely separate discussion, as you all know. So these were the criteria in 2017. The initial non-severe, they had leukocytosis that was less than 15,000, or creatinine that is less than 1.5. Of course, if their creatinine was already above 1.5, and you had to make sure it hadn't increased. And then severe, you see that, leukocytosis and creatinine had gone up some. Fulminant disease, hypertension, shock, ileus, megacolon. And then we talk about, what scenario they fit into, if it's a first recurrence or second and subsequent recurrence. The problem is in the papers, nobody really defines recurrence. It really varies. CDC says 51 days. I don't know whether they came up with 51 days, but it was interesting. Most of the studies and with the going into the trials for like fidaxomicin, it was 3 months. So you had to have a recurrence within 3 months to actually get treated for recurrent disease with their trials with that. There are some papers that look at 6 months. And so that was one of the things early on. It was usually with 2 to 3 months. An early relapse of this is probably going to be within 30 days. So, that's when you start looking at this and they will let you know, hey, things got better. Oh, now they're not. And the thing is, did they, what were they doing at home, or, is this food associated? Did they have antibiotics? I thought I was getting something. I mean, there's all the scenario that everybody hears as to why I started having C. diff again. This came out, this was in 2018, the initial episode for treating it. And this, these were actually recommendations. The recommendation was to use either vanco or fidaxomicin over metronidazole. And the problem was they said, well, you could use either vanco or fidaxomicin because fidaxo was really expensive, and they knew some people couldn't get it, that they were in a hospital, and you say, okay, you can finish this as an outpatient, and they go to buy it, and they're saying, well, it's like $400 with, no, I have insurance. They said, yeah, that's with insurance. It's like a car payment. So that was a problem. So they may have to go to vanco. And then fulminant CDI, as Carter talked about earlier, what to use with this. There was a lot of pushback when I would actually treat people with not really kind of run-of-the-mill skip, but they weren't severe, but they like multiple stools a day. I would give them 250 of vanco, and for about 24 hours. And I got an argument back that, why are you doing that? You have adequate levels in stool, at even 125. Well, the problem is, what's the transit time of that? It doesn't matter. Well, it does, because you're only giving this, 4 times a day. And if they're crapping it out, the reason to give less of it as time goes along with the pulse taper is that you're having less C. diff. You're having more formed stool. So the concentrations are really higher in that than they are when you're having, 10 to 12, 14 bowel movements a day. So yeah, it's fine to back off of it. And that's why that pulse taper mechanism seems to work for many people, not everybody. So that's part of this. I don't know that you need 500, but that's what's in the literature. But for really fulminant disease, it's like if you could fit a kitchen sink in the colon, you probably do that too. Some institutions like Harvard and I think Hopkins have surgeons who were actually very facile, and it's a really complicated surgery of doing a double barrel colostomy, trying to save the colon, and they just infuse everything through it. So, giving them vanco enemas and everything where they can regulate it. And they have quite a bit of success. I think they save like 70% of colons doing that. But it means a lot of surgical procedures. You have to unhook them and then treat them and everything and wait a while and then hook them back up. And we talked about doing it here, and it was just like, yeah, we don't have enough trained people. We can't do it here. So it is something to think about. So this was talking about first and second recurrence. And then you see the thing, I'm not going to go through this because we've already touched on it, but there was a comment about using oral vancomycin followed by rifaximin. The problem with this was this happened at some institutions, especially in some places where they were doing organ transplants, and they had C. diff associated with the antibiotic use, and they started using rifaximin. It worked pretty well initially in one of these trials that I have listed down there, but the rifaximin resistance was like 37% almost of isolates, and then later on, after they started doing this a lot, went up to 81%. And it's not a cheap antibiotic at all. So, rifaximin, I think we have better things. We can give them Fidaxo at this point. So then we changed recommendations in 2021. I do want to point out to you that this document does not say these are recommendations. These are suggestions. Because when you look at it, it did grade, it did everything like you're supposed to, but it said that recommendations were labeled as either strong or conditional. But we recommend as a strong recommendation, we suggest indicates conditional recommendations. All of these we suggest. So when people said, oh, no, it said in 2021 that they recommend, no, actually, they really did. I mean, that's what we do, but technically, that's not what they said. So they did say to use Fenaxo rather than Vanco, although it's an alternative if you can't get it, they can't pay for it. To use Fenaxo as a standard or extended pulse. And if you haven't done extended pulse, one of the recommendations for that is down at the bottom in yellow of using 200 once a day for 7 days, then 200 every other day for the other 13 doses. That's kind of what people have been doing, although I did put it in here that there's some other ways of doing this that people have done and published. And then you see that they did finally talk about Beslo. Yeah, great. We don't have anymore. However, they're looking at other things because I have a trial that's going on. I'm going to mention to you at the end of this for here. And it's using, as one of my colleagues at another facility is using crapsules, as you talked about early. Yes, FMT capsules, and she lovingly calls crapsules. It's very interesting because I'm already trying to do that. We're waiting for somebody to have a recurrence. We haven't had any recurrences yet within the time period of the study. And I got one sent to me, and it's for another monoclonal toxin, C. diff, for recurrences. And it's AstraZeneca. And I said, I can't. I mean, it'll compete with this trial, and I can't do it. It's for recurrences. So I'm sure it got sent out to other people as well. I do want to mention this to you. There was some big brouhaha back, as you see with this stuff. Emergence of clinical Clostridioides difficile isolates with decreased susceptibility to vancomycin, and the last person's name is well known, Herb DuPont. Well, Herb's kind of retired, and has a lab that's ongoing, and the last author is it's their lab and everything else. It's a nice position to have, but they were talking about C. diff strains exhibiting reduced susceptibility to vanco are currently circulating in patient populations of all these different groups you see of different institutions, mostly in Texas. And it says routine susceptibility testing may be necessary, although the caveats with this are there's no CLSI breakpoints for C. diff testing, to look at susceptibility testing. What's the mechanism of causing resistance? They didn't talk about it. Is this regional or really widespread? No discussion. And prior vancomycin use wasn't even discussed with this. So I had a discussion who I've got to know because of the things we've been involved with, is Sue Johnson, who's up in the Chicago VA and part of the university there. He's actually retired, but he's still doing stuff. And so they had a paper that they sent, as you can see, it corresponds to CAD. And so they used a screening media that included vanco to screen for this vanco resistance. That's where this came up with. And they had, these isolates had an elevated vanco MIC that was 4 or greater microgram per ml. But they didn't have any identifying resistance to C. diff in their study, like we talked about. And that just using selective vanco agar, no C. diff vanco resistance was actually found. And maybe what they found wasn't C. diff, but was Clostridioides or Clostridium inoculum, which can be in the gut. It doesn't cause disease. So, and you see at the bottom that, they look very similar. So maybe that's what they were finding. And this kind of just went away after that discussion, is we think you're finding a different organism and making much ado about nothing. These are just a couple of other recommendations, that are in the literature about the Extend trial using Fenaxo. I'm not going to belabor these. I mean, they're there if it's something else you want to look at. There's also this Fenaxomycin chaser following a treatment course of VANC. It was in, OFID in 2014, Fenaxo taper pulse followed by treatment. So these are those really complicated cases where people are just grabbing at anything they can to see if they can, because they had nothing else. I mean, you look at the dates on these, we weren't into doing FMTs. So what else can we do? This is actually an interesting drug. It's very similar to some of the other things that we have. Very narrow spectrum antibiotic agent. And as you see, this was a discussion back in 2022 about ritonidazole. If I can even say it. Ritonidazole. Yes, the R word. You know what this means? It means I need a drink of coffee.
Instead of metronidazole, it's vitinidazole.
Ritonidazole.
Yes, ritonidazole. Thank you. Yes.
It just rolls off the tongue.
Oh, of course it does. And you say, well, this looks interesting. Is there any data with this? As a matter of fact, there is. This is from IDSA, and this is from 2023 of a really nice study. So they compared it to Vanco, and you see that their sustained clinical response was slightly better with RDZ than Vanco. However, realistically, it wasn't a superior. It was, as good as, if you want. So yeah, it was a non-inferiority. But it's the same thing when we started looking at Finaxo versus Vanco, less recurrences. So with that, it's 8.1. So it's in phase 3 trials, and it'll be interesting to see if this makes it to market as another potential tool that we might be able to have in case that, Finaxo starts having issues.
Wow.
So we talked about that. Beslo, a lot of words about nothing now because it's gone. And then the capsules. I did want to just comment, if you're going to do oral FMT, and it's actually in the protocols, that you have to tell people, don't chew the capsule. Why is it in there? Because somebody did. We had conversations about this. Actually, Epidemiological was looking at, and it took them over a year to come up with a gelatin capsule that wouldn't dissolve until it got down into the duodenum. Because that was our, I said, if it breaks down in the stomach and you have eruption, is it a burp or a fart? So we called it a BART. A BART. I know, bad jokes. But it's a real thing. So obviously these are made to not dissolve, in the stomach and to wait till they get down into the small bowel. This all started because of some of these trials that came out that looked really good. This trial got stopped prematurely because FMT looked better than everything else that they were testing. A lot of people were looking at this. There were discussions back and forth. And I don't know, did you go to Vancouver, the IDSA meeting there? There was a pro and con about whether or not to use FMT or not. Dale Gurney goes, of course not. Well, we got all these other things that, he was looking at. And then Johan Bakken, who had done a lot of this because he was from Norway, I think, where they do it. And they use a lot of things like kaffir and some other things to help decrease the amount of it. And he said, he was talking to Dale, and he said, no, this is crazy. We shouldn't be doing that. He says, what are you talking about? It's brown gold. It was a really fun back and forth. But that's why the people started doing it. When I pulled this down, it's been probably a couple of years ago now, just looking at what was being looked at. And there was one on there that you see as the CP101 that said, it was discontinued, the company winding down. That's not true at all. This is still ongoing. So there may be others going on. And you see on there VE303 I'm going to talk to you about, which is what we have to look at now in a phase 3. So this is what you see now that just came out of gastroenterology was looking at this for a phase 2. So you still continue to see some of this coming out. And hopefully once we see more of these drugs coming out, if they look really good, maybe the cost will come down and make it a little easier to do orals. So what do we have now? We have the fecal microbiota live, the JSLM, or when I first saw this, I swear it was a quick glance when it came out. I thought it said red Yoda.
Red Yoda.
Instead of a green Yoda, I had a red Yoda or a red Toyota or something, But it is, as I was told, because they didn't know how you say it, it's rebiota. So the Y is like an I sound. So it's rebiota and the GI. That's the idea. I know. I like red Yoda better. Biota. Diarrhea, you're saying. Pretty good. No, I didn't work on that all night. So this was a rectal enema, and that's part of the problem with this is how far up do enemas go?
Yeah.
And realistically, how far up should it go with this? And how well can people hold this in? And, this is a single dose enema. You don't need bowel prep. And then Ballast, as you nicely talked about, came out in 2023. It's 4 capsules daily for 3 consecutive days. And as you astutely mentioned, you get a 10-ounce bottle of mag citrate the day before starting it. So you're getting a colonoscopy prep before you're getting this. And you have to take this on an empty stomach. So you just had everything blown out of you, and you have to take these capsules and wait 8 hours before you can eat anything.
Right.
So it's not the most pleasant thing, but at least it's, it's a 4-day or 3 day,
3 days.
3 day.
Yeah, you do
Yeah.
it in your house.
Yeah.
Which is-
And do it at your house. So yeah. So this was looking at, you see the two different trials as they were talked about, RBX 2660 and SER 109, the Ecospore 3 with this. And it is interesting. I just show you what you have to do this as an enema. You have to position people. You have to, how far in do you insert the enema tube? So it's one of these two positions. And we were talking about it. Could we do it here? And they said, oh, yeah, we'll just do it over in building 36. I said, probably not. Because if that doesn't get contained, then you have to, I mean, if they've had C. diff, you may have C. diff spores out in the room. And so you have to terminally clean the room, and that's going to kill that room for the rest of the day. So that's semantics is difficult with this. You can't do it at home. It has to be done someplace where that you can do this. And the success rates look pretty good. With Rebioto was 70.5, placebo is 57.5. And, when you start looking at these things, this I wanted to put in because this just came out, Digestive Disease Week, that they have much better results of doing it by colonoscopy. And so this is what, I'm not going to read it all to you, but that they had a 24 to 72 hour washout period after getting treatment. Then they went by colonoscopy, and it looked really good. So they had 39 out of 41. It was about 80+% efficacy. We need more data with this, and the follow-up was 8 weeks. So it'd be nice to have a 3 months or 6 months follow-up to see how it's going. I'm just not sure how they're going to convince people to do it by colonoscopy. We tried that with Open Biome because there were two different products that you could get. One was per upper and the other was per lower. Nobody, except a few people in town, would do it.
I think like the patient that I had who's had multiple recurrences and multiple admissions.
Right.
I think that's the kind of patient that would benefit from this.
Oh, yeah.
Or actually be willing to be like, hey, I'll go colonoscopy if you're gonna really help me.
Yeah. So it's very interesting, and this may be another way of maybe getting a better result than just doing an enema. So this is looking at what you've already talked about, and I'm not going to look at everything, but these are the firmicutes that are there. There's a Clostridium clusters, Eubacterium, Lactobacilli, Bacillus, Faecalibacterium, Roseburia, and Ruminococcus, which sounds like it came from cows. They ruminate. So these are done by single source donations. The donors are really extensively tested, purifications, ethanol inactivation, filtration. The final product has between 1 × 10⁶ and 3 × 10⁷ firmicute spore colony forming units. There are differences between that and some of the other things that are coming out, and these were just the two trials that were done with 2660 and SER 109. So if you're looking at 2660, it's 58.1% efficacy with placebo and 70% with the drug, which we would say was IP, or investigational product in this. But which is interesting because if you start looking at overall the treatment efficacy with this, you could argue that, well, 58.1 of placebo patients got better. If you take that away from the positives, then you had like a 20%.
20%.
And the other one was a little bit better with SER 109, but still, which means you have to pick your patients closely because of the cost. And who you think it's really going to work with? Somebody said, oh, I heard about them crapsules and I want some of them. Yeah, well, okay. Do you have the money? Do you have insurance? I don't have any insurance. Okay. Well, let's see what they can get you with a coupon and stuff, but somebody's going to end up eating some cost. So this is what's going on, and I'm just going to mention a little bit to you, not the whole trial, but this is what we're doing here is the VE303. We're doing a phase 3, and if you look at the difference in, I would argue that maybe you can say that this is, some little bit of propaganda because obviously they want to show what's the difference between what's out there and what they want to look at. So that both of these are from donations. They are live, whether they're spores or not. Spores are live, and it's tough to what if this takes off and everybody likes it and the cost comes down, and now they have to upscale production? How do you do that? If you're relying on donors. So it has pluses and minuses to it. I'm sure that they probably can, but what VE303 was looking at is that every capsule has the same composition. and because they use recombinant monoclonal antibodies in fermentation from cell banks. So this is banked away. Everything's always the same. That being said, we don't have any. If somebody has an occurrence, we have to get it from the company. They don't leave it in our pharmacy because it is not. They don't have a huge amount of it at this point, because it takes a while to make it. So that may be, if they can ramp that up, I think it'll be very interesting. This was actually the paper that came out in JAMA and was very positive with this. So just showing you that they were looking at a low dose and high dose of this versus placebo. The people did much better when they were looking at high dose versus low dose, and that's what's going on in this study is looking at high dose. So this is taking 10 capsules daily for 14 days. That's the high dose. The low dose is 2 capsules for 14 days. Are people going to like taking 10 pills a day or 10 capsules a day for 14 days? Yeah, but the 14 days I think sounds interesting. The other thing I like about this trial that I've had this over the years in a couple of trials is that there is an unblinded arm. Somebody's in this because it's 2-to-1 randomization. If it doesn't work, they're willing because they're blind. We don't know that if they want to go an open label, they can do that. So then we'll know that they had real thing, but they still have to go through the same thing that they did originally. So, and so that's kind of looking at all these difference, between looking at Open Biome, which is really looking to disband and go out of business because they were just doing this so that people could have something until the company started having stuff. So this is just an overall kind of, how things are at this point and what this trial is looking at trying to do. And this is what actually is being looked at. I'm not going to read all these to you, but it's a lot of different types of firmicutes and others that we have. Interestingly enough, we met Friday 2 weeks ago with one of the persons who's working with them who was doing actual bench research with microbiome in the gut. She's a double PhD, really nice lady. And I said, is this all that the company's going to do? No. They're looking at, they have a product that's going into clinical trials that they want to look at for patients with IBD, that actually some of the spores make IL-23, which could be really interesting to try and control it. And they're also going to potentially, and who knows if it'll work, but they're looking at a product that will help decrease the occurrence of ESBL E. coli in the gut. So if it's not in the gut, especially in female patients, they can get colonized, in the vulvovaginal, so maybe that will decrease that. Who knows? So I think you're going to see, like, Dr. Morpardo had said, with some of the research that's going on, over at USF with Dr. Brichot and their colleagues with microbiome. It's going to be very interesting to see what we can come up with of things that are living in us and maybe can, help us. So this is a question somebody asked me, is there going to be a C. diff vaccine? I don't know. Who knows? We were doing a Sanofi one, and yeah, Sanofi and Sanofi and Pfizer, sorry. Dave Johnson, when he was still doing ID over at Bay Pines, had the Pfizer one, and he had recruited a fair amount of people. We had 6. This is like when Ebola was going on and nobody wanted to be in it because the most common thing I heard was, "Oh, be no guinea pig." Nobody had heard of C. diff. I mean, it just, it wasn't like doing shingles vaccine. This was different. And that's all you heard, and was all Ebola this and everything, and everybody's scared to death. So this was part of what we had. They stopped it out of futility. The Pfizer one actually didn't meet its pre-specified primary endpoint, preventing C. diff, but there were some small endpoints that they said, well, medically attended CDI, so people having to get hospitalized and stuff, that maybe that might work better, vaccine over placebo. So I don't know. I doubt that that'll be the end of it, but I don't know who's looking at it at this point. So hopefully that's been okay. A nice review. There's a lot of stuff going on with this. But currently, what do we still have? Testing algorithms now, a little bit better one here. And then looking at Fidaxa, maybe another oral antibiotic, or hopefully more than that, just in case. And maybe a vaccine. But I think the oral FMT is going to be really interesting over the next few years.